Welcome to this clinical walkthrough on a Barrett's esophagus case for UK MLA. Brought to you by Mediate, your 24/7 practice partner.
All right, so in this walkthrough, we are going to tackle a really common and super important scenario, breaking the news about Barrett's esophagus. We're going to break it down into 5 key stages of a really solid consultation, all the way from saying hello and gathering your info, to explaining the diagnosis, putting a management plan together, and wrapping everything up safely. So, let's dive right in. Okay, first things first, the introduction. This is your golden opportunity to build that all-important rapport and really set a collaborative tone for the whole chat. Nailing this part is absolutely crucial. So, let's set the scene. Imagine this. You're in a GP surgery, and your patient is a 55-year-old man who's had acid reflux for ages. He's just had an endoscopy and biopsy, and now he's here for the results. And your job? It's to break the news about his results and figure out what to do next. Now, a simple opening like this, it's gold. It's polite, it confirms who you are and why he's there, and straight away you're asking for permission to proceed. It's a tiny thing, but it immediately makes it feel like you're a team, working on this together.
Right. So before you even think about giving the results, you've got to take a step back and understand what's been going on with the patient. This is where you do a quick, focused history. This is all about getting the context. It shows you're treating a person, not just a piece of paper from the lab.
A fantastic way to structure this is using the ODI paramnemonic. So you're going to ask, how long has this been going on? Is it getting worse? What makes it better or worse? And are there any other symptoms, especially something like trouble swallowing? And what we find out here is that his symptoms are sticking around even with the medication he's on.
Okay, next up, and this is non-negotiable, you have to screen for red flags. FLAWS is a great little mnemonic for this, checking for things like fatigue or weight loss. Then you'll dig into the social history. And bingo, we find some major risk factors we absolutely need to talk about: heavy drinking and a 20-a-day smoking habit.
And this next part, ICE, is honestly one of the most important things you'll do before giving the news. You need to explore his ideas, concerns, and expectations. And right away, you find out his biggest worry. Is it cancer? Knowing that before you say anything else, that's a game changer. It tells you exactly where to focus your reassurance.
All right, you've done the groundwork perfectly. Now it's time to deliver the diagnosis. And the magic formula here is to be clear, be empathetic, and give that reassurance right away.
So, think of it like giving a headline first. You state the diagnosis, Barrett's esophagus, and then you immediately hit him with the good news. The great news is there are no signs of cancer or any precancerous changes. See how that works? You've just tackled his #1 fear head-on.
Okay, now you break down what Barrett's actually is, and please, no complicated medical jargon. You can just say it's a change in the lining of the food pipe because of long-term acid splashing up. Of course, you can drop in the term intestinal metaplasia to show you know your stuff, but then immediately explain it like you would to a friend.
And what's really helpful? An analogy. You can explain that the body, in its own way, has tried to protect the food pipe from all that acid by swapping out the normal lining for something tougher, a bit like the lining of your intestine. It just clicks for the patient, right? It makes this complicated science stuff make sense.
You can practice this exact case right now and get objective feedback on mymediate.com.
So the diagnosis is out in the open. What's next? Well, now you build a management plan. And the key word here is collaborative. You're doing this with the patient, not to them.
And a really clean way to do this is to break it down into 3 main parts. Think of it as 1, the medicine, 2, the lifestyle stuff, and 3, how we're going to keep an eye on things going forward. Let's start with the medication. He's still having symptoms on 20 milligrams of omeprazole, right? So the textbook next step is to double that dose to 40 milligrams to really get that acid under control. And you've got to explain how to take it properly, about 30 minutes before food for it to actually work. Mentioning you'll monitor him long-term also shows you're on top of your game.
Now for the lifestyle changes. And this is huge. You need to make it crystal clear that this is just as important as any pill he's going to take. For this guy, smoking and alcohol are the big ones, and you should definitely offer to refer him for support. But you also need to cover weight, diet, and even simple things like propping his head up at night.
And finally, the surveillance plan. So, what's the follow-up? Well, according to the national guidelines for his specific situation, which is non-dysplastic Barrett's under 10 centimeters, a repeat endoscopy every 3 years is the standard. You've got to be clear that this is just a routine checkup, a way to keep tabs on things.
Okay, we're on the home stretch now, closing the consultation.
Your goal here is to make absolutely sure the patient leaves feeling listened to, understood, and totally clear on what happens next.
And what do you think we need to do? You've got to circle back to his biggest fear. Remember that question from the beginning? Don't just assume he's okay now. Address it directly. Again, bring it up yourself if you have to.
And your answer has to be a firm, clear no. Then back it up. Explain why. It isn't cancer, and, this is the key bit, there are no precancerous changes. It's really helpful to put that risk into perspective for him by saying most people with Barrett's live totally normal lives and never have any problems. Now, he's probably going to have other questions, right? Like, why did this happen? Which is a perfect chance to link it back to the reflux and the lifestyle factors you discussed. And another big one, why not just take it out now? You need to explain that at this very early stage, the risks of doing a procedure are way, way higher than the benefits of simply watching and waiting.
And you'll wrap things up by giving him a super clear timeline. Let's book a follow-up in about 4 to 6 weeks to see how he's doing on the new dose. That's your safety net. And then you remind him about the 3-year plan for the next scope. He should walk out of there knowing exactly what the roadmap looks like.
You can practice this exact case now on mymediate.com.